Welcome to the ERC Guidelines 2025. My name is Tino Greif. I'm the Director of Guidelines and ILCOR for the ERC. And today, this is the first webinar in a series of 3 where we present the different guidelines. Today, we have 3 excellent speakers, Jess Soar, Carsten Lott, and Jerry Nolan, who are presenting adult life support, post-resuscitation care, and the special circumstances. First of all, I have my co-host here, Jacqueline.
Hi, my name is Jacqueline, and I'm going to be the co-moderator of this webinar, mainly going through the Q&A and looking at all of the questions that you guys are sending in. So if there are any burning questions that you have during the talk, you're welcome to use the Q&A box at the bottom of this screen and type in your questions. If you type in your email address with the questions, we can maybe get back to you if we don't manage to address them during the webinar. And if that doesn't answer your questions, we can ask you to send in your questions to webinar@erc.edu at the end of the webinar, when you can request a letter of attendance for attending this today. Back over to you, Tino.
Yeah, thanks. All this will be recorded, and you might watch this or whoever via the ERC webpage. Please, as Jack said, type in your questions into the Q&A box. And with any further ado, we switch to Jess about advanced life support.
Good evening. It's a great pleasure to talk to you about the 2025 ERC Adult ALS Guidelines. My name's Jess Soar, and as you've heard, I was the lead for the working group. I'm an intensivist in Bristol, UK. You can see some of my conflicts and previous roles below on the slides. Now, I'm just going to start off by saying we had a large writing group, and it covered a wide range of specialties and clinical backgrounds. And I'd like to thank everybody involved in the guidelines. We also had a public consultation period where we could get feedback to help improve the guidelines before they finally came out. And we're just going to start at the beginning. So this is the 2021 chain of survival, and it sort of shows a continuum between recognition, starting CPR to buy time, early defibrillation to restart the heart, and ALS is sort of hidden in that ring, and then post-resuscitation care. For 2025, we have a new updated chain of survival, and advanced life support does get a bigger mention in this continuum, because we're hoping most people will either avoid cardiac arrest or get early basic life support and have their hearts restarted. But those who don't, they need more advanced interventions where this third ring comes in, and that includes CPR, drugs, and other interventions. And for the first time in this new chain of survival, we're recognizing the importance of, once you've restarted the heart, to restore people to their normal function and restart quality of life. And we recognize that in the guidelines. So for the first time in the ALS guidelines, we actually had a public patient representative, Gareth, who's actually a cardiac arrest survivor, and he had input into the guidelines and added in his values and preferences. Now, this is the 2021 algorithm, and not a lot's really changed in 2025. So the design has changed, but the core information hasn't changed. But there are changes in emphasis, and most of these changes in emphasis are happening in these boxes at the bottom. And I'm going to pick out a few key issues in the next 10 minutes or so. Starting CPR is the same. There's still shockable, non-shockable rhythms. You shockable rhythms, you do CPR for non-shockable rhythms, and the 4Hs and 4Ts remain the same. Now, I'm just going to pick out some of those important things in this infographic here. So, starting advanced life support early is important. We've emphasized both high quality chest compressions and ventilation, and I'll go into that in more detail. Giving defibrillation early, which is already part of a change of survival, but getting people to actually put the pads in the correct place, and also switching pad position if VF is refractory, giving early IV adrenaline for non-shockable rhythms, identifying and treating reversible causes without delay. I'm just going to cover some of these in more detail. So most of our interventions, and this is just taken from the Paramedic 2 study, which shows adrenaline versus placebo, work best when given early. So you could have all the best interventions in the world, but if you turn up late, they're not going to work. So all these ALS interventions, their effectiveness decreases over time. And if you look at data from around Europe, we're getting much better at getting ROSC. So for in-hospital cardiac arrests in the UK, half of patients get ROSC. At a hospital, about 25–30% of patients get ROSC. So the earlier you can get ROSC, you're more likely to save the brain. So early interventions work best. We've always said high quality chest compression. So in someone who's unresponsive with absent or abnormal breathing, and if you're capable of doing it, no palpable pulse, you start high quality chest compressions early. But for advanced life support, it's also important that you ensure effective ventilation. And the reason for this is that a lot of people now start compression only CPR. So by the time ALS is started, ventilation becomes more important. And there's data from this large US study where this was a study comparing 30:2 versus continuous compressions with continuous unsynchronized ventilation. But when they looked at nearly 2,000 patients having 30:2 ventilation, and this is in a trial with skilled paramedics, EMTs in North America, they looked at what happened in those 2 ventilation pauses. So in these 2,000 patients, they had 27,000 pauses, and there was only detectable ventilation in 40% of pauses. That means in most patients getting advanced life support from skilled rescuers in this study, they got no ventilation. And the patients who did get ventilation did better for ROSC, survival, neurological function. And that's why we've made effective, high-quality chest compressions and ventilations an important part of Guidelines 2025. And I think most of us might recognise this in cases we've done. And it's even a problem with mechanical CPR. There's similar studies. Patients don't often get the 2 ventilations and the pauses. Airway and ventilation hasn't changed in Guidelines 2025. We still recommend a stepwise approach, but we're recognising that bag mask ventilation isn't an easy skill. So unless you're doing it as an expert anaesthetist intensivist all the time, for most people, this requires a 2-person technique. And we've sort of emphasised the use of supraglottic airways more in the guideline a bit, and we've also tried to point people towards airways that are easy to use, easy to learn, and have large RCTs. And tracheal intubation should only be used by those people who have high success rates, or systems that have high success rates, and using waveform capnography to confirm tracheal tube placement. Early defibrillation is a key part of the chain of survival. I'm not going to go into it, but everybody recognizes, if you get a shock within minutes, you have very good chance of good survival. And every minute delay causes a significant delay or worsening outcome. What we also recognize is that when people have done studies, people don't put the pads in the correct place. And this was in Guidelines 2018, Guidelines 2021. And again, now we're actually have pictures and more emphasis on this. You have to put the apical pad in the correct place. And the correct place in both a male and a female is just below the armpit and not at the front of the chest, not over the abdomen and over the stomach. It's got to be quite high up, under the armpit, the apical pad. And the other thing that's always been in the guidelines is that if initial shocks are failing with an anterolateral pad position, consider changing to an anterior-posterior pad position. And again, this isn't new. All we've done is sort of underlined it more in Guidelines 2025. What we haven't recommended is combining anterolateral and AP shocks. So double sequence external defibrillation is not currently recommended in the ERC guideline. And I know there's lots of people out there saying, well, there's this Canadian, North American RCT that showed it work. But we've looked at that trial and we don't think it reaches a threshold for changing the guidelines. It was just done before, during COVID. It was stopped early. The results from the intention to treat analysis and the protocol analysis raise questions. And there are several current RCTs going on. And clearly, if they show this is a great intervention, we will change the guidelines, but not yet, because we think some of the improvement may just be from putting the pads in the right place or the vector change. Finally, early IV adrenaline for non-shockable cardiac arrest. I'm going to go back to the Paramedic 2 study. Actually, I'm going to go back a step. So give IV adrenaline early. And by IV, we mean IV, not IO, because there's been a large RCT that compared IV with IO. In fact, there's been 3 large RCTs, and they all point towards better ROSC with IV and less cost. And importantly, everybody thinks IO is quicker, but in the studies, when they've put them side by side, it takes just as long to get an IO in, connect it all up, and give a dose of drugs. So we're going to say have up to 2 attempts at IV, or if IV is not feasible, only then consider IO. So IO has been de-emphasized a little bit in these 2025 guidelines. Again, once you've got your IV in, if you've got a non-shockable rhythm, give your IV adrenaline early. And this is just data for ROSC from the Paramedic 2 trial, which shows a significantly better outcome with early adrenaline in non-shockable rhythms. That difference is much smaller for shockable rhythms. And in fact, giving early adrenaline may potentially be a bit harmful in shockable rhythms, but for non-shockable rhythms, early adrenaline. Drug doses and timing. There's been quite a lot of emails to me about this, and we have clarified them. So if you click on this QR code, and I'll leave it up for a few moments, there are quite a lot of flowcharts that this QR code links to that shows when drugs should be given during CPR. I'm not going to go through them all in detail, but I'll just show you what the QR code leads to. So if you have shockable rhythms, we just point out when to give the first dose of adrenaline and amiodarone, which is after 3 sequential shocks. If you have a non-shockable rhythm, you give the adrenaline early, as soon as possible, during the first 2 minutes of CPR. This is the one that's caused most sort of confusion, and I'm not going to spend a long time on this, but if you have a witnessed and monitored VF arrest and the pads are already on and you're ready to go, you can give up to 3 stacked shocks. But once you've given your 3 stacked shocks, you count those 3 stacked shocks as the first dose for the purposes of using the ALS algorithm. So you then give your adrenaline and amiodarone as if those 3 stacked shocks were the first shock. Again, read it in more detail on the actual guideline paper. I'm coming up to my end of my 14 minutes, so this is stacked shocks. I'm sure there's going to be lots of questions. We have introduced some new things. One of those is ALS in highly monitored settings, where we've talked about titrated adrenaline. So if you've got an arterial line in and capnography and you're in like an operating theatre, you may not want to give 1 milligram of adrenaline straight away. And we've given some targets to aim for if you've got highly monitored patients. So aiming for a diastolic greater than 30 millimeters of mercury on your arterial line, aiming for an end-tidal CA2 of 25 millimeters or 3.3 kilopascals. And this is only really going to be feasible in highly monitored settings, but cardiac arrests in those settings are relatively common, and the people working in those settings should be able to work towards these goals. I'm going to stop there. Start ALS early, every second counts, give effective ventilations as well as chest compressions. Remember to put your pads in the right place and change position, IV adrenaline early and non-shockable rhythms. And one more thing, identify and treat reversible causes without delay. Thank you very much.
Thanks, Jess, for this clear explanation. There are several questions coming in. Maybe we have time for 2 of them. Jackie?
We've got the vector change. And one of the questions is the role of vector change in the context of 3 stacked shocks, and at what point you would change the pad position.
Yeah. So fortunately for me, people will only get 3 stacked shocks in very expert settings. You know, they've got the pads on, it'll be the cath lab, it'll be operating rooms, cardiac surgery, and so on. So the physicians or the nurses, whoever's managing it, should be able to decide when they want to switch. You know, so we've not said exactly when you switch, because if that's what you're going to do, you can decide when it's easiest to roll the patient. If you're doing an intervention on the patient, you might decide to go down some other routes. But once those shocks are failing, yeah, people do need to consider whether they change your pad position. But by doing that, we mean putting on a fresh set of new pads in the alternative position.
And just to follow up on that, is there a way to optimize vector change if they're also pre-charging the defibrillators?
I think ultimately you've got to minimize hands-off time. So if people are pre-charging, they've got to make a quick decision to shock after they've stopped compressions. Yeah, so unless they're practicing this, it's sort of like you can't spend a lot of time deciding it's shockable or non-shockable. Okay.
I think that's all we have time for right now, and we're going to have to go on to the next speaker, but we'll discuss more at the end. So our next
Thank
speaker
you.
is Gary Nolan.
Thanks so much indeed, Chaplain. So I've been tasked with talking about post-resuscitation care. It's a pleasure to talk on this topic, as ever. I'll see if I can get these slides to advance. I don't have any major conflicts of interest in this, other than the fact I was the lead author of these guidelines, and I'm editor-in-chief of resuscitation. I guess those are the main ones. I also would very much like to thank my co-authors, and I'm also, like Jazz has done, going to point out that amongst those co-authors is Paul Swindell, who's a cardiac arrest survivor. So we were using his contributions in these guidelines as well. And most important, you can see there that I put up 2 publications because this was a collaboration between the European Resuscitation Council and the European Society of Intensive Care Medicine. And I particularly like to thank Claudio Sandroni, who was really a sort of equal first author of these guidelines. He represented Ezekiel. I think it's very important that we've got the European Intensive Care Medicine on board, because that's going to improve, I think, implementation of these guidelines. So this is the algorithm. I know that's very difficult to see, but I'm going to highlight the key points here. The structure of it is very similar to 2021. So we've got these three domains: the immediate treatment phase, diagnostic phase, and then the optimizing recovery phase, which is the main ICU bit, really. The first bit up here is immediate treatment. This, of course, could happen anywhere. It depends wherever return of spontaneous circulation has occurred. So it could be out of hospital, for example, it could be even on a ward. So the guidance there, which I'm not going to go into detail yet, is really aimed to a situation where you've probably got perhaps minimal monitoring. So we're talking about systolic blood pressure targets, for example, down here, whereas later on we talk about mean arterial pressure when we've got things like invasive lines. I'm going to go on because I want to focus more on the later stages of this algorithm. So this is the diagnostic phase here. And if you follow this down through, there are some subtle differences, which I'm going to highlight in a moment from the 2021 version. So if it's a likely cardiac cause and there's ST elevation on the ECG and or electrical hemodynamic instability, then these patients require urgent coronary angiography plus or minus PCI if that's indicated. So they go down this route here. And then afterwards, if a cardiac cause is not identified or there are other concerns, then consider head-to-toe pelvis CT scan is in here, and that's relatively new. I'll come back to more detail on that in a moment. If it's not a likely cardiac cause, then what we're suggesting here is going straight for potential head-to-pelvis CT scan. And then patients were admitted to the ICU. Just to highlight the subtle change around angiography is in the group of patients that do not have ST elevation on their ECGs, but are still considered as possible cardiac cause, but are otherwise stable. These are patients that have been actually extensively investigated. And this is a meta-analysis you can see here. Down the bottom are the non-randomized trials. And the sort of bottom line for these studies were there was a suggestion or benefit from early coronary angiography. But if you look at the randomized controlled trials at the top color up here, you can see that estimate there sits squarely above the line of neutrality, or actually slightly drifting towards against early coronary angiography. So for those reasons, there has been more emphasis on delaying coronary angiography in those patients that don't have ST elevation on their ECGs, as long as they don't have signs of significant cardiac instability, such as electrical or hemodynamic instability. So the other I suppose new emphasis is around the concept of this head-to-pelvis CT scanning. This, of course, is really a concept that's been taken from major trauma patients. And the reason for this is there are now several observational studies, such as the one that I'm showing you here, that suggest that these patients are put through a CT scan. You do pick up a lot of either diagnostic issues. Now, they could be acute in terms of cause of the cardiac arrest, or they could be picking up long-standing problems such as chronic ischemic strokes, as demonstrated here. Or perhaps even more importantly, you do pick up a lot of CPR-related injuries, some of which are actually going to require intervention. So this is the reason for this emphasis around head-to-pelvis CT scanning. And there are some centres around the world now where they will put pretty well every patient through an early head-to-pelvis CT after resuscitation from particularly out-of-hospital cardiac arrest. And that there is pretty well summarising. This is taken word for word from the guidelines, pretty well summarising what I've said there. I guess the only thing I would emphasise is the head-to-pelvis CT becomes particularly important if those patients have signs or symptoms pre-arrest suggesting a non-coronary cause, as written. So let's move on down our algorithm. We come to the bottom bit now, which is really, I guess, the most significant bit as far as our intensive care management of these patients is concerned. And if we look at some of these in detail now, first of all, oxygen targets. I haven't got time to go into all the evidence behind this, but I think this is perhaps one of the most important studies in terms of changing some of the guidance that we have. This was the exact trial, was pre-hospital study, randomized patients with ROS, either to have a standard sort of 100% oxygen initially, targeting sats of 98 to 100, or titrating the oxygen so that it's bringing the oxygen saturations down to 90 to 94%. bottom line is, in terms of survival at discharge, no significant difference. However, the trend, if it's anything, against the low targeted group. But if you look at the bottom of the slide, probably the reason for that is that there was many more of these patients that had significantly hypoxic episodes before their ICU admission, probably because it's actually very difficult to titrate oxygen in that way immediately after cardiac arrest. So the guidance now is to continue to use 100% oxygen immediately after OSC until you can reliably measure oxygen saturation, either by oximetry or blood gases. And then once you can get that reliably done, then you're going to target essentially normoxia, as you can see from those values there. We've added in a warning about pulse oximetry in darker skin tones, so we know that there is racial bias in these oximeters, so we need to be particularly careful in patients with darker skin tones. What about carbon dioxide targets? Again, I'm just going to show you that the key study here, which is the TAME trial, randomized trial in ICU, comparing mild hypercapnia, so slightly higher CO2 values, with normocapnia. And the reason for that was there was some data suggesting that maybe hypercapnia was beneficial. In fact, this trial showed no significant difference, as you can see here, in terms of favorable neurological outcome. So our recommendations now are to aim for normocapnia in these patients. Blood pressure targets, again, there's quite a lot of data, but I'm just showing you the one study which I think is probably the best study. This is the box trial, where they actually very cleverly blinded clinicians because they offset the monitors they were using to monitor blood pressure and simply told them to target a MAP of 70. And the clinicians were therefore unaware whether they were actually targeting a MAP of 77 or 63. They got good separation, as you can see here on the A of that slide there. But if you look at the outcomes, again, it's a neutral trial. So no significant difference in terms of blood pressure targets. There has been a meta-analysis of that box trial combined with the few other studies that we've got. In essence, dichotomizing these studies into targets above 70 and below 70. And as you can see here, there is no significant difference. This point estimate sits over the line of neutrality, but if anything, slightly favoring a lower MAP, surprisingly, than a higher one. So if we look at our recommendations for hemodynamic monitoring and management, you can see here we're recommending an arterial line for these patients, which of course I would imagine standard practice in most hospitals, recommending obviously the early use of echocardiography. But that's our blood pressure target there, as you can see, a mean of 60 to 65. I think the main thing is, before I go on to comment about temperature control, is obviously in many cases we probably need to individualize our targets. So I've given you a sort of very general principles, but there will be reasons to have, for example, higher or lower blood pressure in certain patient populations. What about temperature control? Always controversial. I'm putting up this one slide, which is really an individual patient meta-analysis of the two TTM trials. So what we've been able to do here is combine and compare 33, so mild hypothermia, with either 36 or normothermia. So they were the two controls used in those two TTM trials. The reason I'm showing this slide is you can scan down and look at all the different subgroups here, because people have always saying, well, this study doesn't represent our patients. There may be certain subgroups that benefit from colder temperatures. But if you scan down here, there's really no evidence of that, maybe except for the down at the bystander group down here, bystander CPR with no bystander CPR, trending towards favoring the hypothermia group. But that's one subgroup in many. So we have to be careful how we interpret that. So these are our guidelines for 2025 in terms of temperature control. So they're pretty well the same as 2021. So we're suggesting active prevention of fever and certainly preventing temperatures higher than 37.5. So not all of these patients are going to need temperature control devices, for example. We think, based on one of the TTM trials, that probably about half of them may need temperature control devices to keep that temperature down below that level. And then the rest of these recommendations here are largely unchanged from previously. Just so that you're in the loop with what's happening in the future, we hopefully will have more data, certainly around the use of temperature control devices, because that's one of the components of this STEP care trial, which has got 3 separate domains looking at sedation, temperature control with or without a feedback device. And they're also looking at the question of blood pressure targets, as you can see there. So we look forward to the results of that trial in due course. I'm not sure when it's well advanced in terms of patient recruitment. So whether there will be a result sometime, possibly next year, I'm not sure. General ICU principles for these patients. I mean, the best thing I can do is probably directly to the guidelines themselves. I've really put up the main items here, pretty well word for word, in terms of what's in the guidelines. I think nearly all of these are what you would probably be doing for general critical care patients, so that there's nothing particularly special for the cardiac arrest ones. Maybe the top one I should highlight, which is we're recommending not routinely using prophylactic antibiotics, but having a low threshold for giving them if there is a suspicion of pneumonia. I want to just leave time for prognostication, because I think this is an area where there has been a significant change from 2021. This is the new 2025 prognostication algorithm. For those of you familiar with the last one, it's similar on this left side of the algorithm. And certainly what we're again looking at is patients who remain unconscious. This time, though, they can enter the algorithm with a motor score of 5 or less, which is a higher motor score than we had before. We're usually looking at this at 72 hours or later, and we're trying to identify at least 2 unfavorable signs as an indication that a poor neurological outcome is very unlikely. As you can see down here, I don't have time to go into all of these individually, but they are largely the same as 2021. The new bit of this algorithm is in the center here, and that is we've added on the concept of some signs suggesting a favorable outcome. And so if you've got any favorable sign, and they're listed down here, and you can see, then that means a good neurological outcome is likely. So this removes some of the patients from the gray area. So some patients that don't fulfill these criteria, if they do have favorable signs, we can strongly suggest that a good outcome is likely. It's not definite, but it's likely. We still, however, have a significant number of patients in the gray zone out here on the right of the slide. And for those, we are going to continue to observe and continue reevaluation. So this is the really the summary of my presentation. It's the equivalent graphic that Jazz has just shown. We've covered all of these areas except for this one here. And I think that's an important one, which I haven't got time to go into any great detail, but emphasizing the need for identifying patients that are likely to need rehabilitation, and not just patients, potentially co-survivors as well. And that's something that I think globally we do pretty badly, and something we can certainly improve. And with that, I'm very happy to take any questions.
Thanks, Jerry. I guess we have time for 1 or maybe 2 questions, Shaq.
So one question, Jerry, is about the head to pelvis CT, and if this were done, if it would also be able to identify pulmonary embolism and aortic dissection.
Yeah, no, absolutely. And I didn't have time to go into all the details about everything, but certainly part of that head to pelvis CT scan protocol, which, by the way, we are trying to work certainly in the UK with our radiologists to come up with a sort of standardized protocol, would include CT pulmonary angiography. So certainly would be aiming to exclude PEs, and it would also pick up aortic dissection as well. What I didn't have time to say is that some parts of the world, they're including CT coronary angiography in that scan. And I think that's a very interesting area, which as technology improves, I wouldn't be surprised if that becomes more standard. But it certainly isn't standard in most centers at the moment.
Thank you. Back over to you, Tino.
Yeah, thanks. Time is going on. Our next speaker is Carsten Lotz, who was the lead for the enormously large guidelines on special circumstances. Carsten, please.
So can you hear me now?
Yeah.
Oh, fine. Yeah, because I lost the button for my mic. So good evening, everybody, and welcome. I'm happy to be able to present work of our group on special circumstances in cardiac arrest. As you can see, we had a huge number of experts involved. I'm happy that our sister societies contributed to that chapter. And I'm happy that we even found somebody who's an expert in sports from football, Tim Meyer, who has been able to contribute to the chapter on cardiac arrest in sports. So now I can forward. Yes. So I do not have any financial conflict of interest. I'm ERC Director, Training Education. So these are our key messages. You heard a lot about advanced life support. You heard something about basic life support and about post-resusc care. And what I'm going to show you within the next few slides is where are ways to look to the left and to the right of the ALS algorithm, and whenever you need to even modify the ALS algorithm if it's needed. So most important, and so the chapter is divided into 3 different parts. But this is what you know from the guidelines 21. So we are talking about special courses, special settings, and special patient groups. We have a number of general recommendations. You always need to initiate resuscitation following the standard ALS algorithm in cardiac arrest. But nevertheless, and this is something where Jazz already reflected on, if appropriate or where appropriate, you have to prioritize treating the reversible causes, and especially for some special circumstances, even if chest compressions are briefly interrupted. So this is where we need to leave our overall mantra in having chest compressions uninterrupted as long as possible. So I will get you through some indications where you need to prioritize other interventions than starting with chest compressions. You know the reversible causes, so I do not need to repeat them. Number 1 in our chapter is anaphylaxis. So standard measures you need to undertake is you need to recognize it as prompt as possible. The instruments you have available for that is your standard ABCDE approach, and you have skin changes, changing the skin of the patient that might get in the way. What you need to do is you need to stop or to remove the trigger if possible, and then it's the well-known adrenaline, 0.5 milligrams intramuscular, and you need to repeat it within 5 minutes if needed. In this version of the guidelines, we recommend against the routine use of prednisolone, especially in patients with cardiac arrest, as there's some work out there clearly indicating that neurologic outcome of patients where prednisolone has been used in anaphylaxis is worse than if it has not been used. And there's additional information on antihistamine medication. So this can be given, but only if adrenaline is not delayed. Next one is hyperkalemia. So you have at least to do 2 things in the hyperkalemic patients. You have to try to shift potassium into the cells. And we have the standard insulin glucose approach for that. You can use salbutamol 10 to 20 milligrams in a nebulized format. And we still recommend the use of calcium and in cardiac arrest of sodium bicarbonate for that approach. We had a lot of discussion about calcium, as you know, in ALS, it is not recommended anymore. But if you look at the published data on that, the hyperkalemic patients have been excluded from the study. And so we decided, following the discussion in the expert group, to still recommend use of calcium in severe hyperkalemia and in the hyperkalemic cardiac arrest. Following the 21 guidelines, we still recommend to remove potassium in patients who can intake the sodium zirconium in an oral way, and otherwise you need to go for dialysis and eventually consider eCPR. This gets us into the dialysis patient. Yeah, so dialysis patient in cardiac arrest, what you need to do is you need to stop dialysis and if possible to return the blood, not to have a hypovolemic patient in the end. If your dialysis machine is not defibrillation proof, you have to disconnect it before giving shocks, and you can use your dialysis access for giving drugs to your patient. Next one, and this we have a number of pretty complicated algorithms, is hypothermia. So hypothermia, definition for hypothermia is a core temperature below 35 degrees of Celsius. And you need to check for vital signs. Yeah, so if you have a patient that has obvious signs of death, then you need to consider termination of CPR even at that stage. If your patient is not impaired, hasn't got impaired consciousness, then our recommendation is to get them to the nearest hospital as soon as possible. If they have an impaired consciousness, you're looking for vital signs, and you're even trying to calculate the HOPE score as soon as possible, to get an idea if that patient is going to benefit from ECLS. If so, you should get the patient into hospital as soon as possible to undertake that measures. We have a new algorithm for avalanches, for avalanche victims. So the first measure you have to take is you have to look for the duration of the burial within the avalanche. If it's less than 60 minutes, then you have to check for asphyxia in your patient, and you need to check for signs of life as you do in the standard ALS algorithms. If you have signs of life present, then you start with 5 residue breath, and you should start CPR as soon as possible. The core temperature should be measured in the esophagus as soon as possible. And then you should follow the standard algorithm to manage that patient. Looking to hypothermia, then you need to follow the universal ALS algorithm if the patient requires CPR. If the patient has a core temperature above 40.5 degrees of Celsius, then you should go for rapid cooling, and we recommend the cold water immersion. This should be done until the core temperature is below 39 degrees of Celsius. You should check the blood sodium in that patient and follow the respective algorithms, and you should provide them with fluids if they are severely dehydrated. Next one is thrombosis. Yes, the thrombosis. First one is the pulmonary embolism. So you have ideas, you can get ideas about that if you look at your ET CO2 values during resuscitation. While performing high-quality chest compressions, pulmonary embolism is likely if you are not able to produce ET CO2 values above 1.7 kilopascals or 30 millimeters of mercury. We recommend the use of fibrinolytic drugs for cardiac arrest patients if the pulmonary embolism is the suspected cause of cardiac arrest. We recommend use of fibrinolytic drugs, surgical embolectomy, or percutaneous mechanical thrombectomy if pulmonary embolism is the known cause of cardiac arrest. And once again, you should consider eCPR as rescue therapy. If you look at coronary thrombosis, Jerry already talked you through that. So in STEMI patients, go for cath lab as soon as possible, and in non-STEMI patients, check for other underlying reasons first. Getting us into traumatic cardiac arrest. So the algorithm is barely changed. Nevertheless, we tried to get some clarifications within this algorithm. So we have an extra box indicating that you should perform interventions based on the clinical priority and not in a sequential way, because this has been a feedback from the 21 algorithms that people started following that algorithm step by step, and this is not our intention. Our intention is to manage the reversible causes in the patient with a traumatic cardiac arrest following the clinical priority and not in a sequential way. We have been discussing chest compressions. We still are not sure about the effectiveness of chest compressions in patients with traumatic cardiac arrest. You can have a compromised ventricular filling in hypovolemic patients, in patients with a cardiac tamponator, and patients with a potential pneumothorax. You can have a reduced cardiac output during chest compressions in patients with a pseudo-PEA. So what you should do is you should minimize the interruption in chest compressions. The chest compressions must not delay immediate treatment of the reversible causes. And this is always a case-by-case decision based on your resources and on the clinical setting. What about inotropes and vasopressors in traumatic cardiac arrest? The role still remains unclear. There are no data supporting them, but they might be a bridge to management of reversible causes. Looking at the relevant reversible causes, so we're talking about hypovolemia. Should try to stop bleeding as first step, and then you need to provide volume for your patients. In an ideal world, you can put them on blood transfusion as soon as possible. In 21, we still had the resuscitative endovascular balloon occlusion of the aorta on board. But in the meantime, we have sufficient data to clearly only recommend REBOA in clinical studies, but not as routine use. Then you have hypoxia, so give them oxygen. You have tension pneumothorax, needs to be treated by mini thoracostomy, and we still have the cardiac tamponade. Resuscitative thoracotomy, we have some data on that coming out of the UK, clearly indicating that it might be useful in penetrating trauma. We do not really have adequate results in blunt trauma. We still stick to the 4E. So if performing that intervention, you should have the necessary expertise, the equipment in place. The environment should be capable of doing that, and the elapsed time should not exceed, we still stick to the 15 minutes. Looking at cardiac arrest in the cath lab, we followed the algorithm we already presented in 21. So you need to take preventive measures and you should be prepared. You should be able to detect cardiac arrest as soon as possible. You should use echocardiography if available, and you should react and activate the resuscitation team as soon as possible. Follow the standard ALS algorithm in your patient, and Jess already reflected on stacked shocks if you have your defibrillation setting available. What about the operating room? We have a number of reports on cardiac arrest in the operating room coming up in the close past. So what you need to do, you need to take preventive measures as well. So you need to screen your patients, and you need to have a good communication within the OR about critical procedures. You need to check, you need to monitor your patients properly. If you have a sudden drop in blood pressure below 50 millimeters of mercury, accompanied by a drop in the end tidal CO2 concentration, despite proper interventions, you should start CPR. You should inform the OR team of cardiac arrest and start delivering high-quality chest compressions. For that, usually you need to adjust the height of the operation table to improve the effectivity, the efficiency of your chest compressions. Airway needs to be ensured. You need to ventilate with 100% of oxygen. You should trace your ETCO2 to have an idea about airway and the quality of chest compressions. If available, you can use ultrasound to address reversible causes. And if conventional CPR is failing, you can consider early eCPR. Trained surgeons might be able to perform open chest cardiac compressions if eCPR is unavailable. And overall, if working in the UR, the human factors are crucial. And we have been talking about local anesthetic systemic toxicity in the OR setting. If that is the case, you should stop the local anesthetic as soon as possible, hyperventilate your patients to increase the plasma pH with metabolic acidosis. You should give low IV adrenaline, around about 1 mic per kilogram body weight. Then start them on lipid emulsions, 1.5 milliliter per kilo body weight, followed by infusion. Yeah. If there's no ROS, get 5 minutes, but this is nothing new as well. Should double the lipid infusion rate and consider prolonged resuscitation and ECPR. Seizures need to be treated as you're used to with benzodiazepines and IV anesthetics. In post-cardiac surgery patients, you need to prevent the event and need to be prepared for your cardiac arrest patients. You need to detect it as soon as possible. And the most important one, as we already stated in 21, the patients in VF-VT, if applicable, should be treated following the stacked shock approach. In asystole or extreme bradycardia, you should start them on the pacemaker as soon as possible. New one in the 25 guidelines is the left ventricular assist device. Provide an algorithm for that as well, where we clearly indicate that you should prioritize the device control with an experienced team over chest compressions if possible before you start chest compressions and standard advanced life support on your patients. Looking at sports, screening is a big topic in sports, and you need to do a risk assessment in everybody doing sport to adequately prevent cardiac arrests in sports. And what we learned in sports is that you can use sports, especially football, for awareness campaigns to raise awareness about cardiac arrest. In the EMS, we recommend not to manually compress during or within driving ambulances. We recommend mechanical chest compressions in that cases, and if available, to establish invasive blood pressure monitoring as soon as possible to start the post-resus period in the patient, ideally already on scene. Pectus excavatum, a new chapter in special circumstances as well. You will find reduced chest compression depths of 3 to 4 centimeters in the patient. As you can see in that slide, there's a NUS bar for correction and NUTS bar for correction in the pectus excavatum patient, and this complicates chest compressions. You need a substantially increased force in these patients. You should consider early ECPR if chest compressions are ineffective, and the ideal way to provide defibrillation for these patients is the anterior posterior PET placement. And last one is about pregnancy. We have some pictures on the correct way of doing the manual left uterine displacement. Otherwise, I'm going to go over that. We reflect on the resuscitative hysterotomy. This is still recommended as a time-sensitive intervention. Preparation to perform that procedure should be undertaken as early as possible, but nevertheless, it should be performed as soon as possible at the site of cardiac arrest, but it should be done by a skilled team. Many thanks.
Okay, thanks, Carsten. We see the announcement of the next webinar already, which is also good. So the second part of the series will be covering BLS, basic life support, epidemiology system, and the last one I forgot, but it will come up at the end again. Jack, some questions for Carsten. Time is running.
All right, so some quick questions for Carsten. There are a couple of people who want some clarification on anaphylaxis and if there is an IV line, whether the adrenaline should be given IV or IO.
No, so it's neither it's neither IV nor IO. It's intramuscular. This is what we recommend, yeah, because it prolongs the time where the adrenaline is working. Yeah, so first approach should always be the intramuscular approach.
And as a follow-up question for Jerry, there's another question about IV lines and central lines, and which would the preferred be if both are available and patent?
So this was with reference though to drug delivery. So that's presumably for ALS, isn't it? But the answer would be if you've got a central line already in position, that would be the best line to use because it's going to get far more rapid delivery of the drug centrally. But maybe I've misunderstood the question.
No, I think you've answered the question that the participant had in mind. Jazz, there's a question for you on extracorporeal CPR and its role in ALS.
It does have a role in refractory cardiac arrest, but in select patients. So it's not going to work for everybody. It's going to work for someone who's had good CPR and a reversible cause, and only in systems so they can establish it fairly rapidly. So unless you've got a system that can get you onto ECPR within 45 to 60 minutes at the top end, and then reverse your underlying cause, it's not something available to everybody. So ECPR has a role in select patients who are failing ALS.
And so another question for Karsten is on pulmonary embolism and the recommended drug doses, and mainly about timings of administration of these drugs if there is a PE.
So timing in cardiac arrest is clear. Yeah, so you should give it as a bolus. Yeah, otherwise it doesn't really work. Yeah. Recommendation on the correct dosage. So no, this I cannot give you. I cannot provide that at the moment. Yeah.
And going back to the stacked shocks that we discussed before, if there is an arrest that needs stacked shocks, Jazz, can you clarify at what point do you give the drugs? Is it after the third stacked shock or is it later on in the algorithm?
You count those stacked shocks as the first shock for the algorithm. So again, look in the paper, go to the QR code, and it tells you exactly when to give these drugs. So any stacked shocks count as the first shock for the algorithm. But the reason we say stacked shocks, and this is an important point, is that if you witness VF and shock it very early, the chances are the first or second shock will be successful anyway. So hopefully you'll never get to needing any drugs because you've been so slick at shocking the VF that the first shock will be very effective.
I guess we are coming to the end. I might ask you three. So maybe Jerry, if you one sentence, one take-home message from the post-resuscitation care.
So I think that the take-home message for me is that the quality of care that's delivered to the patient post-ROSC does affect neurological outcome for these patients. So I think we have to be very methodical and careful about the way we deliver that. And certainly when it comes to prognostication, extreme caution before making any withdrawal of treatment decisions.
Mm-hmm. Jess, what would be your take-home message?
Start ALS early and do your interventions effectively. So effective compressions, ventilations, defibrillation, drugs, reversible causes.
Mm-hmm. Karsten, take-home message?
Yeah, adding to that, prioritize reversible causes where needed, but still take care that chest compressions are not interrupted longer as needed.
Okay. Jacques, for the closure?
Just to remind everyone that if you'd like to receive a letter of attendance for this webinar, the place to email would be webinar@erc.edu. And if there are any questions that were asked during the chat that we weren't able to answer, you can add your questions into that email and we'll try to forward that onto the speakers. And lastly, you have the slide up about the next webinar in the series, which will be on Monday, the 8th of December. at 7 o'clock, and there will be highlights from the BLS guideline, epidemiology, system saving lives, and PLS. So we hope that you can all attend that as well. Thank you very much for joining tonight.
Thank you.
Thanks. And bye.